One of the things that you get to do when you're my age is say, I've sat in meetings for a long time, and much of what I've heard today, I heard in the 1980s. And what I'm going to hope to do in the brief minutes I have with you is suggest that there is a better way than talking against each other and sort of talking about we should use computers, we shouldn't use computers. I think there's some lessons we've learned that hopefully I can give to you. I'd like to start by figuring out how to do the slides. Good. I look at severity scores by three reasons you want to do them. One, you want to better describe patients in clinical trials or in registries. Two, you want to have an objective measure of whether patients are improving or not. And I've heard today that people say, well, I know a patient's improving or not. I'm a doctor. I know how to do that. Yes, you do. But you're a human being and you have biases. You remember your most recent cases better than you remember cases 10 years ago. You don't, or you're not able to process a huge number of variables, and you're dealing with an extraordinarily complex problem. And the third thing is you would like to be able to evaluate new therapies and see if they work better or not. Now, please notice, there's one thing that's not on this slide, triage. You're having a discussion about keeping it simple versus complexity. Where you want to keep it simple is for a triage tool. Severity scores are not for triage. The SKY classification that I read is the triage tool, and that has to be simple. But once you have a simple triage tool, and then you get into clinical trials, registries, you must deal with the complexity of the problem. So separate those two. Don't commingle them, okay? You need something simple that the EMTs, the hospitalists, whoever you want to identify, can use to get the patients that you want to your center faster than they're coming. I understand that. That's not the role of a severity score, because you want something that can go quickly. But once you've arrived at a center of excellence or a shock center, then you want to have to deal with the complexity of the problem. So the current status, as I looked at the literature, is represented in what I heard this morning. You've got a lot of scores. You've got some very good scores, but none of them are really seen as robust enough to handle all those three things, being good for clinical trials and registries, helping to identify patients, and helping to evaluate new therapies. And you have a very complex problem. Now, there's two ways that this severity issue gets addressed. One is that something is so good that it gets everybody behind it and it becomes the standard. I was fortunate in that APACHE became that standard within ICUs. That's not going to happen here. You've got too much disagreement. You've got too many scores running around. The nice thing is it's very easy to create a new score. That's also the bad thing. So you're going to have lots of people doing it. My message to you is that unless you can develop consensus among yourselves and force that consensus to be used uniformly, there's not going to be much progress, and you'll be doing the same thing and talking the same way as you are this morning 30 years from now. So what I would do, and these are just suggestions based on my experience, I am not an expert in your field. I looked at your literature. I understand what your problem is, and these are just suggestions that come from me. But I would design 3 scores, because I don't think my experience would say that one score is not going to be appropriate for all of those indications. I would have an admission score that would be used for clinical trial and registry use. I would have a dynamic score that would help to tell me which patients are getting better or worse. And then I would have a research base, because I think you're seeing emerge that cardiogenic shock is not just pump failure, it's also got a metabolic component. So I would, again, there has to be a point at which your field reaches consensus and begins to be uniform in what it does, or you can just keep talking across each other. So I would, and these variables here are not necessarily the ones that you would use. What this is description of a process. I would get people together, many of the people who had developed the scores, many of the people in this panel, and many of the people in this room, get people from different perspectives together and force a consensus about what that admission score would be. Here are some suggestions. Again, they are all available on admission. So you want a score that you can do when the patient enters the trial or enters the registry or comes to that shock center for the first time. And these are just examples. The SCI classification is used as part of this. But again, that's a triage tool. That's not what this is. This is an admission score that begins to develop and express the complexity of the problem. Then I would develop a response score. Everything in that admission score was non-invasive. It should be available on admission of the patient. Then you have a response score that you're going to be measuring over time. That's going to be invasive. You can't get away from it. The problem you're dealing with is a very complex hemodynamic problem, and you're going to have a lot of information about it. And I would use, as a beginning, these invasive measures. I'm not sure what I would do with inotropes. I think you need to have a consensus about that and have a discussion about it. I would not use any of the mechanical therapies because they're clearly controversial. They're not used in a uniform way. And as a general principle, please stay away from putting therapy into a severity score. It's usually not a good idea because you're trying to evaluate therapy with that score. So I would use measurements that are independent of therapy as opposed to putting therapy in as a measure of a severity. And finally, as we've heard, I would look at some of these inflammatory and immune response variables that you see emerging. And I would begin to look at them and say, we want to be able eventually to incorporate these things as part of both an admission and potentially a response to therapy score, because it is a metabolic problem in addition to being a hemodynamic problem. So I would begin to look and to see these. And I would recognize that you're right, in the future, the computerization of medical records is getting better. One of the things that kept APACHE from progressing and kept APACHE 2 being the most popular severity score, because it's on one sheet of paper and it's relatively simple. We are now able, and there's going to be regulations announced very shortly by this administration, that are going to mandate a national data exchange standard for medical information. That's going to make it possible to pull information from electronic records in a much more simpler way than was possible in my lifetime. That's going to change. So I would urge you to recognize that the complexity of developing something, there's not going to be a data burden because you will be able to write programs that pull that data from electronic medical records. So I would develop this consensus. I would put some weightings behind them. The first thing to recognize is that sometimes it's more important to have the right variables chosen, and the weightings will come over time as the databases grow, and you'll be able to change those as you learn more about it. So admission score measured when they enter a trial or when they enter a registry, response to therapy as you're treating them over time, and then research-based scores. That way you could look at groups from registries and you could say, gee whiz, one registry has much sicker patients than the other one does. You could look at a clinical trial and you could say, gee whiz, that randomization really did randomize well. It balanced out patients in the control and experimental group. Finally, you could use it, the response to therapy score. You could say, look, let's compare these three therapies. Obviously, the therapy in red is much better than the other therapies. Likewise, you could begin to look at individual patient responses, and you could say there are patients who are clearly not responding at all and are an extremist. There are patients who are intermediate, where you really don't know. And finally, there are patients who appear to be responding. And this response to therapy score may help you in communication as well as in research. Thank you very much.
Any questions, comments? Marvin? I think that's right on. I mean, the point is you can't use, one thing for all these different things. They have different motivations and purposes. So if you dissect them the way you've done, I think it's right on the money. And I think down the road, once you get all that insight, I'm talking several years down the road, then perhaps you can homogenize a few together as things kind of evolve. But I think really right up to the point.
The problem with administrative databases is that these patients are so incredibly complex over a course of therapy that the Amin article that everybody's squawking about in circulation, they looked at balloon pump versus Impella, and the administrative database couldn't sort out if the patient started on the balloon pump and then deteriorated, went into Impella. And so they only counted the good outcomes from the balloon pump group. If they switched over to Impella, then they were counted in the Impella arm, and those patients are going to specifically do worse because they already failed one therapy. So I just wonder about, our ability to mine these databases down the road. I think it's really, they're very complex, and to try to compare one to another when the outcome in the course could be so different. I wonder if you'd comment on that.
Sure. You're absolutely right. Administrative databases have been used historically because why did computers come into medicine? The billing office brought them, okay? It was to make sure that we maximized billing and we got the right bill sent out. That's why administrative databases are so sophisticated, because they were the first ones to come in. What I'm suggesting to you is over this decade, over the period of time the majority of you in this room will be working on this field, there are going to be improvements in the availability of electronic clinical data. You will be able to interface and pull data from your EMR, clinical data, detailed data, the immune responses, the inflammatory responses, the hemodynamic responses. You won't have to rely on administrative data. You will have access to real clinical data and very granular clinical data. And I would suggest that, again, if you are going to try to address and understand better a very complex problem, you've got to deal with the complexity. And the human brain, while it's extraordinary in many things and always needs to stay at the bedside, needs to also recognize that the processing of variables, doing multivariate equations, algorithms in your head, is not something that human beings do well.
Professor Knaus, that was really illuminating, especially the third category of response to therapy. Can you think of an example in a prospective way that a study defined this to be useful clinically? So in the SHOC-1 trial, there was a post-hoc analysis of responder, non-responders. And we know the data, and we say, okay, those that responded better, got better. And that was great, but they were different kind of people. Is there anything prospectively or from a randomized trial that somebody actually did to say, I am going to choose, based on the criteria that I know work, an enriched population for a treatment effect?
Off the top of my head, I can't cite you a specific study. I think I can find one for you, and if you give me your contact information afterwards, I'll send it to you. But I don't, again, I can't remember as much as I've seen and know. I just can't do it. So, but I'd be happy to provide that information because I'm sure it's out there.
So I think it's a great idea to talk about an admission score and a response score and a research score. I wonder if you comment on the issue of timing with respect to a response score or a research score. So you have initial values and then you have later values, and how do you deal with that? Do you deal with a change over time? That's sort of the challenge.
Yeah.
And to add to the complexity, people come to the admission at different times in their disease process.
Right. And those are empiric questions which need to be answered. You can begin, once you have consensus, and again, this is a political problem. This isn't a medical problem. If you can't develop consensus and use the same thing, again, you're going to be repeating this conversation 3 decades from now. So, and what I would do is say, when you have consensus on the variables you're using and the kind of response score you're using, then you can test whether looking at changes over time, looking at the delta between 6 hours and 8 hours, Is that the best way to do it? Or is the delta by every 4 hours? Those are empiric questions that will be answered once you have data in hand that you can compare one approach to the other approach.
All right, thank you very much, and we will continue and